you have ringing in the ears, we must understand what is the cause of the condition and what are the symptoms. Today, we are here with Dr. Michael Golenhofen, ENT physician from Germany, who will share his expertise here on the Treble Health podcast about the best treatments for tinnitus and how targeting the causes is a better method than targeting the symptoms and the common mistakes that many doctors are making when it comes to managing tinnitus. My name is Dr. Ben Thompson, audiologist, founder of the Treble Health podcast. Dr. Michael Golenhofen, please introduce yourself here to our community.
Yeah, thank you very much for inviting me, first of all, and it's really a pleasure to be on your channel. So I'm just an ENT physician specializing in the treatment of tinnitus patients and vertigo dizziness patients in Germany. And I do this work since a couple of decades now. And what turned out to be the most important is to try to be very specific when it comes to understand the problem, the condition a patient is in. So this is what I'm specializing in. I published a little bit, but generally I understand myself as a practitioner, and that's my daily work.
When we talk about the manifestation of ringing in the ears or ringing in the brain, one of the times that we met previously here on my YouTube channel, you shared your published research on the different subtypes and causes of tinnitus, breaking it down into these three major categories: hearing loss, hearing damage, number one; number two, somatic or somatosensory conditions, often related to the jaw or the neck; and then stress-induced condition, which is a simplification of a phenomenon between the brain and the central nervous system. What are the key points there? Some of us have heard you share and talk about this before. What are the key points? Let's refresh on the key points. And then from there, we're going to build a case as to what is the best treatment for tinnitus depending on the different subcauses.
Mm-hmm. Yeah, the very principle, the idea behind this differentiation was to bring more clarity in the moment when a patient and a doctor encounter, when they meet and the patient tells the story. And there are so many different conditions that can cause a tinnitus perception that it is overwhelming for so many healthcare professionals, and also irritating for many patients because they lose the hope that an answer to their questions will be found at all. And this is why I try to do this kind of work to simplify things. You know, there may be like 30, 35, maybe 40 different conditions published that can cause tinnitus. But when it comes down to our daily practice, as a matter of fact, it's those three that you mentioned that build an amount of approximately 80% of the disorders causing the tinnitus perception. Then there are maybe three more, and then you're up to 95%. So to simplify things, I try to show this classification in order to help that more practitioners can work with a causal approach in the assessment and treating of tinnitus patients. That was the idea behind it.
And for those listening, when we say a causal approach for tinnitus, it's to understand that tinnitus itself is a symptom. The different possible causes create this manifestation of the symptom. Therefore, correct me if I'm wrong, tinnitus itself is not a disease.
That's absolutely correct. And that's maybe already one of the most important elements we need to make clear to ourselves when we work in this field. The tinnitus sound, as different as it shows in a human being, in daily practice, it's so much simplified nowadays. We only talk about the tinnitus sound. We do not even ask the question, is it on the right ear, on the left ear? Is it bilateral? Is it maybe different sounds? And so on. So it is important to listen how the symptom actually is present. And from there, we always try to find the disorder behind it. You know, when we have in front of us the question, okay, there is a symptom called tinnitus. What's the condition behind it? What's the disease behind it? And when we do this very first important step, then we have already accomplished so much more than many other people would would experience in their meeting with a healthcare professional. And because only a few really do this very important first step that you just pointed out. It's extremely important to realize it's a symptom. We want to know what's behind it.
And we often can find out. We often can have strategies and treatments that get to the root cause, even if it is a long-term condition, even though it is something that takes time to shift and reduce. When the effect happens, it's real. You and I both know that. We're going to go into details, so stick around if you're listening. We're going to go into further details and explain these different causes, the different symptoms that they have, and then the best treatments to target those causes. That ultimately is what can set us free from bothersome tinnitus. Now, it's important to say, as with any medical condition, there is never a 100% treatment effectiveness. However, with tinnitus, through collaborations like this, through research, through clinical expertise, we get better and better over time. So despite not having a cure for ringing in the ears, the treatments available are better and the diagnoses are better. Dr. Golenhofen, let's talk about what the medical community and doctors, audiologists, ear, nose, and throat doctors, all of us collectively, let's talk about the things that we do wrong, the common mistakes that occur along the way, whether that's diagnosis or treatment. Would you like to go first?
Yeah, I think the most important mistake that we make very often is that we have so much information available. Before our conversation today, I looked up what the British Tinnitus Association, the German, the American have published already, and there is so much information in there. And actually, there is the necessary foundation there to make a proper differential diagnosis, to find out or to at least think about what's the disorder behind the tinnitus perception. But as a matter of fact, as clear as those subtypes of disorders and those tinnitus symptoms that follow these disorders actually are, there's one bar in almost all flowchart of these tinnitus communities that says, if possible, do a causal treatment. If not, refer to a symptomatic treatment. Okay. And it seems to be so extremely difficult, obviously, to stick to the causal treatment and the diagnostic. And many of us, maybe almost like 95%, quickly jump from the symptom to the symptomatic therapy. And this is not good. I think this is the actual fault that we do. And I see us as ENT physicians in the responsibility for that, because we would have to do the necessary work to do a differential diagnosis, tell, okay, this is the disorder behind it, and to bring patients into the necessary treatment. So the main responsibility I definitely see in the hands of the ENT physicians. Sorry to say, but it is
yes.
a fact.
And perhaps one of the earliest mistakes, common mistakes that happens along this way is for an individual who has ringing in the ears to go to their ENT clinic, because that's usually the first point of a professional fully understanding and giving them a verdict, an answer. Perhaps the first most common mistake is to take tinnitus as a collective tinnitus, as you've shared previously, the tinnitus. Well, that's not accurate. Categorizing it with a blanket statement of the tinnitus. And then to add salt to the wound is to say, well, you just have to learn how to live with it. Very cold, very flat.
Yeah.
That can trigger the psychological brain and make the symptom worse. So inadvertently, although they're trying to provide some realistic outlook here, inadvertently, that makes the condition worse. Would you say that's one of the most common mistakes here?
Definitely. For me, this is very often one of these very hard moments in the beginning of a conversation to a patient. The moment you realize that this malinformation has been given. And in this very moment, a very specific kind of hopelessness starts, because either consciously or unconsciously, you realize as a patient, the doctor on the other side of the table is not really on a path to help me, but I start to fall into a hole of hopelessness because there is no real exit strategy here, no realistic way to go, which would actually be so easy. But as a matter of fact, that's a moment where I feel very sad and sometimes angry because I realize we could do better. We could do better. As ENT physicians, we do have the task to exclude serious conditions. That's one of our primary tasks. Yes, of course it is. But when we see there is no serious disorder behind it, and we're close to those most common conditions that you already mentioned, then we need another approach. We need to step further in a constructive and a positive counseling in a positive way to really help patients.
Yes, and I will add on to that. Oftentimes, the first specialist that someone sees for ringing in the ears is an ENT clinic, and typically that involves a hearing test by an audiologist, as well as the ENT doctor to review all of the results, medical, physical inspection, and provide a response. Now, the ENT doctor may say, I don't have any solution for you. There's no medical cause that I know of, or there's no medical treatment here. So let's bring you to the audiology side of things. And sometimes this can be managing the symptom and promoting habituation. The stress-related subtype, in my opinion, is one that through one-on-one therapy, through one-on-one counseling, we're changing the brain neurons very close to the causal region. I would like your opinion on that in just a moment. I want to comment, one of the biggest mistakes audiologists make is describing that the only real cause of tinnitus is hearing loss. And there's such a logical flaw to this argument, which is, for most people, hearing loss is slow and progressive, very, very slow and progressive over time, meaning that over the last, let's say a 65-year-old female patient comes into the clinic with sudden onset tinnitus. Well, over the last 20 years, slowly but surely, she's been losing her hearing, perhaps at a rate of 1 decibel or less per year in the higher pitches, the higher frequencies. So that's been a slow, gradual change. She may or may not even notice a hearing loss. But then there's a sudden onset of tinnitus over a matter of days, weeks, or months. Things go from essentially not a problem. I either never noticed tinnitus ringing in the ears, or I did, but it wasn't an issue. And then in a pretty rapid period, it goes to loud levels, quite bothersome, affecting my quality of life. So if hearing loss was the only cause of tinnitus, it's not a logical argument to think that such a gradual condition would create this sudden onset of tinnitus that's in a shorter time frame. Any thoughts on that?
Well, that's absolutely accurate what you say. And to state, as an ENT physician or as an audiologist, your hearing loss is the reason for your tinnitus perception after hearing maybe a decade less in the high-pitch area and then have a sudden onset of a tinnitus perception. The statement, the hearing loss is the cause, is simply a false statement. So what is accurate is to say your hearing loss does promote to some extent the onset of a tinnitus perception. This is correct. And then you tell the story of the fact that millions of people hear the same way, but they do not perceive a tinnitus. Okay. I like to say the hearing loss is giving an invitation for the onset of a tinnitus perception, but you don't need to follow the invitation. Okay, this makes things much more understandable. And beside the fact that it is a false statement, it also leaves a patient with an explanation that is false, and the unconscious or the subconscious of the patient asks, so what's actually happening here? You know, there's irritation, there's misunderstanding, there's malinformation. And this is so toxic for a tinnitus patient that we simply don't want to have it. It's very important. It belongs to a good counseling to explain the actual cause of a tinnitus perception. It is a very important first step for a good counseling and for the whole history of a patient afterwards. You know, as a first counselor, you can do so much well when you do it in a way that it is constructive for the patient, that she or he can work with it and understand, oh, I see. So if I would wear a hearing aid with my hearing loss, that would help to a certain extent because my brain has more auditory input, so it will lower my tinnitus perception, but it is not the only cause. Then things get so much clearer, and this is very helpful.
That's an important point, is that hearing aids absolutely help. In our experience, sound therapy, when programmed properly by a tinnitus specialized audiologist over a period of time, helps facilitate this habituation, the recovery, the brain's ability, as you have previously said, to defocus and lower the filter, bringing tinnitus lower in the perception. My favorite example of habituation to sound is when I take a breath in and out through my nose and I pay attention to it. It's a normal speed of breath, normal rate. I can hear the sound when I'm paying attention to it. Yet for all of my day, I'm never thinking about the sound. So that's my favorite example of habituation to sound that people can understand. Aha, you're telling me that over time, my tinnitus can become less this constant ringing and more of a neutral body sensation, like the breathing in through my nose. And the answer is yes. Yeah, I would love to hear your opinion on the overall rate of success with tinnitus treatment. And of course, those of us in our field, you and your clinic, our company, Treble Health, are focused on getting more specific on the cause, more specific on the treatment. What have you seen over time with the success rate when you are operating in the best standard of care?
I like to say that we can help almost every patient when we're doing the right thing in tinnitus treatment, when we try to focus on the cause, on the condition that is the cause for the tinnitus perception, and then we try to do our best to alleviate the symptom. And hearing aids are an integral and very important part of this treatment for the inner ear subtype. Okay, there's a whole subtype around the inner ear function. When it's a slow onset that you described, then there is even more, of course, to the work with a hearing aid. It helps to restore cognitive function to some extent the moment someone begins to wear the hearing aid. And a better hearing in the high frequency area is such an important element to a human communicative life and so on. It lowers distress when I am communicating on my work site. It is such a tremendous help in everyday life. And because it takes out the distress in everyday life, it helps to improve my tinnitus symptoms because it helps me to get more balance, to reduce my stress level, and so on. So when you ask what's the success rate in the inner ear subtype and the cochlear subtype, the hearing aid plays an important and integral role. And we have a very high success rate. That doesn't mean we can bring back high-pitch hearing, okay? We need to know that. We cannot do miracles here, but we know what to do and what we can do for help. And this is our work. This is important. And this is why I say we can help more than 90% of our patients. That doesn't mean they lose their tinnitus always, even if in some subtypes it's our aim, that's what we focus on. And in the central subtype that you just described, we want to bring the ratio from I hear the tinnitus like 80%, I don't hear it 20%. We want to bring it gradually to I hear it 20%, I don't hear it 80%. Then my life is fine. We need to make up realistic therapeutical goals and not to live with fantasies. I want to get rid of my tinnitus today or tomorrow to 100%. But the more realistic we are in our therapeutical goals, the more helpful it is and the more distress it takes out of the relationship.
When we think about success with tinnitus treatment, just as you said, it's about marginal but important gains and improvements over time. Silence is not necessarily the goal, but collectively, we're trying everything possible to get you as close as we can. So you had shared with me previously that most doctors tend to stick to the symptomatic treatment. Talk to me about the central subtype, explaining the distress and the bothersome and the anxiety aspect of tinnitus, the limbic system, the emotional brain activity. For that subtype, what are the treatments you find to be most closely targeting the cause?
Yeah, very important question, of course, because the central subtype, what we call the thalamocortical dysrhythmia, the inner conflicts that create this distress, this tension inside myself. In general, as humans, we have a very dynamic hearing system. Okay, we have, since it is a bioelectrical system, we have some kind of baseline tinnitus sound, okay, like a hi-fi set that you turn on the volume, you hear some kind of sound without hearing music. The same kind of baseline activity we have in our human auditory system, which is like a high-pitched sound. Some people describe it like a cricket sound, some more like the TV set, a high-pitched sound. So there, in our auditory system, there's always a tinnitus sound. We will never get rid of it until we die. And then we have a filter system that we put over this tinnitus sound so that we do not hear it consciously. This is the situation. And then we have two phenomena. We can increase the loudness of the tinnitus sound through some kind of medication, for example, some toxic agents that alter our metabolism, even fever. Like the changes that happen in our central nervous system when we have fever, puts up the loudness of the tinnitus sound. And then there is this filter system that we put over the sound, and that actually follows a very old mechanism that has to do with the inner distress level, because it wants to protect us from predators. That's when it was created, like 100 million years ago. And we deactivate the filter system the moment we feel distress and we want to protect our existence, because we sense a predator around us that we want to hear. Okay, so this is basically the mechanism. And that's why the central subtype is the one where we feel this kind of distress in our system. We have a sleep disorder, we feel distressed, our performance level goes down. All these chronic distress syndrome symptoms that bring with them the fact that we tend to deactivate the filter system. And that's why during a very stressful time, we tend to say, oh, all of a sudden I heard some tinnitus, then it was gone for a while. But with time, it some kind of got louder and louder, and then it was there all the time. This is the typical story patients tell us. But still, it's just the filter system and the tinnitus sound. So if we want to bring the best help to these patients, that's what we need to explain them, okay? Then the whole distress disappears around the fact there's a tinnitus sound, there may not be any tinnitus sound, it's dangerous, it makes me deaf one day, etc., etc., etc. So a tinnitus sound in the human auditory system is the most natural thing on earth. And then we help to activate the filter system by just telling the story. Imagine you're under your shower. Would you say you hear a tinnitus sound then? Most patients say, no, I don't. Of course you don't, because it is masked through the high frequency of the falling water drops and so on. And this is the start of a constructive kind of counseling, of some educational approach, and then leading to some kinds of therapy that help to win the patient for by saying, see, all we need to do is to reduce your distress level, and let's seek a specialist that helps you to do this kind of work. And if you like, you have this kind of hearing loss, you can add to it some auditory stimulation. And then you gradually walk along this path. And this will lead you to success. No worries, you do not have any kind of severe condition or disorder that makes you deaf or whatever not. These misunderstandings would have been told beforehand. And this makes sense. Then we create health in the patient. This is what we want to do.
Yes, I appreciate that. That is independently exactly how I and many of my professional colleagues, and certainly our team at Treble Health, are approaching the management of tinnitus. It's not a question of, do I get help for the cause or do I get help for the symptom? It's both, simultaneous. Do both. So for the cause, as you said, It's the information, it's the one-on-one counseling, the one-on-one therapy, the one-on-one explanation on how this is happening. And for those of you who know about tinnitus retraining therapy, that is one of the fundamentals of that approach is explaining, education, to take the mystery away, take the unknown away, take the fear away from this condition, from this sound, because that part of our brain that's trying to keep us alive, that's the primary job, to keep us alive, is going to categorize that symptom, that sound of tinnitus, more in the neutral category, closer to my breathing in and out, and farther away from the sound of a potential threat or a danger or a predator. So from our side of this, as audiologists who specialize in ringing in the ears, in tinnitus, it's great to hear what you said, is that the best approach in this kind of central subtype, which is quite common in my opinion, is, and I would love for you to validate that, is that what you found in your research, that the central subtype has at least some representation in a majority of cases, or less than 50%? What did you find in your research?
I found it being present in about 35 to 40%. It's a very huge amount of or percentage of the tinnitus patient group as a whole. And it is most important. Definitely it is. Definitely it is. When you hear tinnitus experts right now, and that's my criticism, you only hear the subtype. They explain that subtype very precisely, and no question about it. Even CBT is an appropriate method to treat those patients. No doubt about it. As a one-on-one therapy, as a, maybe if you like, as an app, CBT is an appropriate treatment method for this subtype, no question. Beside the fact that many other subtypes carry the central subtype a little bit along with them, simply because the focus of attention is so much pulled to any auditory perception that it very often is accompanying the other subtype in some ways.
Yeah,
but again,
I do appreciate that perspective, is the one-on-one therapy, whether someone is following CBT, cognitive behavioral therapy, whether someone is following tinnitus retraining therapy, or whether someone is seeking a tinnitus expert who likely does a combination of all of the methods, the central subtype need that information, whether it's through an app or one-on-one. We're both clear on that. What you're pointing out intelligently is that for the audiology community, for audiologists to generalize and say, this is what every tinnitus patient needs, we say, not so fast, because you may be missing on the very cause that has the most effective treatment behind it. Now, you have an extensive history of not only identifying this, but also referring these patients to other medical professionals, reviewing tests, and walking them through the process. I know personally, because we see patients who fall into the other subtype categories as well with Treble Health, that we are recommending they get certain medical tests locally. Oftentimes they have to wait weeks or months for those tests. Then the test results come back. Then who understands the whole case? Someone has to be the champion of this case to make sense of it, because the individual going through it has to make these decisions, hopefully with some guidance on, where do I spend my time? Do I get this procedure? Do I get that treatment? And where do I spend money if I have to purchase some of these things? It can be very overwhelming. So do you have any opinions or guidance on that?
Yes, that is maybe the central and the most important point that you just described when it comes to, I have made the diagnosis, what am I doing then? Also understanding that having an accurate diagnosis doesn't mean that the treatment will be easy. In fact, when it comes to a tinnitus perception, those treatments are mostly very difficult to do. Not only the psychotherapy around the central subtype, maybe most simple, the auditory, audiostimulative therapies in hearing loss, when it is primarily the inner ear. But in the other subtypes, it's getting extremely difficult to do an accurate therapy and even to round up the diagnostic process. On one hand, it is very crucial and important, as you pointed out, that we make a network, that we create a network around us of experts that we can refer our patients to. We do not need to do anything by ourselves. and we cannot do. So I refer the patient to the next expert and asking the question, do you see this kind of disorder? I see a tinnitus perception. I would assume the disorder underlying the tinnitus perception lies in your field. Please give me feedback. Okay, this is the process. This is actually not too difficult, but then somebody needs to hold the thread in the hands and say, okay, please go there. What's the result? This would be the best to do, and so on, and so on, and so on. And this is, as a matter of fact, a very difficult task. And it is possible, but it is difficult. It is difficult.
It's difficult for a few reasons. I know that in the United States, doctors are very busy. As a private company, we've had the freedom to create our programs with more time and more focus on this condition, on tinnitus. Yeah. The reason why most doctors are not able to maybe hold someone's hand during all of this is because of the complexity of the medical system and various other factors. But we're both in agreement that the patient, the individual, should not know what to do because it's complex and overwhelming, and having a roadmap, having guidance along the way, whether it's from an ENT, an audiologist, is valuable to make sense of it all. Because once we get all these tests, we have a full 360-degree view of what's happening physically, psychologically, et cetera. Then what? Then we need to keep going, keep doing the treatments, whether it's treating a cause that's something different or promoting habituation in the central region. That's our mission. And I thank you for all that you've done here by being a guest on this podcast. I know you've personally offered to provide some training to our team of audiologists at Treble Health. So I want to say thank you. And collectively, this is our mission.
Definitely. And this is something I do with joy, because I think it's so important. And there's not so many teams that work with this kind of expertise. And I really appreciate your work in New York City. I mean, we're like 3,000 nautical miles away from each other, but I think we're all connected with our mission to improve the tinnitus situation for those patients. And as a matter of fact, especially in the somatic subtype, it becomes so extremely difficult and complex. And that's why it needs some guidance. At the same time, I'm convinced that it is very important to explain to the patient what is happening, what the causal situation of the tinnitus perception is. Even if you just say, okay, the somatic subtype is a loss of sensory motor integrity. You have lost the balance inside your sensory motor system. And this is already an explanation patients can work very, very well with. Then the details are sometimes so difficult that it is, extremely complex. But again, let's take the patients along with us on our path and keep them informed about what's happening to them.
Absolutely. If you're watching right now and you found this video helpful, please leave a comment, helpful, and we will continue to make more information accessible to you about tinnitus. If you have suspicion of what is the subtype of your tinnitus, please do ask an expert. Watch the next video in this series, which will pop up on the end screen here and in the description in just a moment. And that will cover the 10 most common somatic causes of tinnitus, which include TMJ, jaw, neck, as well as other conditions. Dr. Michael Golenhofen and I will produce that video and share that at the end of this. Dr. Golenhofen, thank you for sharing. Do you have any last words for the tinnitus community?
I really appreciate your work and the fact that we can do this kind of podcast. And I think I said it last time, do not give up. Keep on searching for the cause and for the improvement of your tinnitus situation. There's no reason to give up. Just stay on the path of finding out and seeking help. That would be my message.
Thank you so much. We have Dr. Michael Golenhofen, ENT doctor in Germany. My name is Dr. Ben Thompson, audiologist, founder of TrebleHealth.com. This is the Treble Health Podcast. Thank you for being here, and we'll see you on the next episode. Bye-bye.